Okay. Uh, okay. During this presentation, I'm gonna describe a systematic and algorithmic approach to recognize certain adult heart disease on the frontal chest radiograph. Usually, we first assess the heart size by measuring the cardiothoracic ratio, which is the A over B, the maximum transverse diameter of the heart, divided by the greatest internal diameter of the thoracic cage from inside rib to inside rib. And if it's more than 50%, we can have either true cardiac enlargement or apparent cardiomegaly, such as due to extracardiac causes, such as suboptimal inspiration. In expiration, the diaphragm moves upward and compresses the heart, making the heart appear larger than it would be in full inspiration. Obesity, pregnancy, and ascites are conditions that prevent adequate inspiration and thus lead to apparent cardiomegaly. Other causes include pectus excavatum, rotation, and pericardial effusion. AP portable supine chest radiograph are the most common cause of apparent cardiomegaly due to magnification of the heart due to AP projection. So how do we estimate the heart size on portable AP radiograph? So depending on the appearance, if we have a borderline enlarged heart on AP studies, usually the probable heart size would be normal. And if the heart is significantly enlarged, it's enlarged. And in this case, as we can see, the left heart border is touching the left lateral chest wall. So definitely we have an enlarged heart. The lateral chest radiograph also help us in recognizing cardiomegaly. So when the heart enlarged, the posterior border may extend to overlap the anterior border of the spine, such as in this case. Okay. Okay. After assessing the heart size, we should next assess the 7 cardiac contours, because we could have a normal heart size with an abnormal heart, such as in cases of obstruction to outflow of blood from the ventricle, where the ventricles will hypertrophy with no apparent cardiac enlargement. I will start from the right heart border from top to bottom. Then we'll switch to the left heart border, the contours on the left side from top to bottom. So the ascending aorta, the first one, normally it should never project farther to the right than the right heart border. This is a case of aortic stenosis, where we have an enlarged ascending aorta and it's projecting farther to the right than it should be. The other contour, we should check for the double density of left atrial enlargement. As we can see here, we have another overlapping density due to atrial enlargement, better seen on this radiograph. So we have double right heart contour due to left atrial enlargement. Next is the right atrium. And usually the right atrium will almost never enlarge without concomitant enlargement of the right ventricle. Okay, and how does it appear on radiograph? We can measure it both ways, horizontally and vertically. Horizontally, we could take the right lateral border to the midline. If it's more than 5.5 centimeter, we could say we have right atrial enlargement. Also, we should measure the height of the right atrial convexity. If it's more than 50% of the cardiovascular height, as in this case, we could say we have a right atrial enlargement. Okay, now we're gonna check the left heart contour. The aortic knob is a radiographic, not anatomic structure seen on frontal chest radiograph and formed by the foreshortened aortic arch together with a portion of the proximal descending aorta. And usually it should not be more than 35 millimeter. How do we measure it? We check the lateral border of air in the trachea here to the lateral border of the aortic knob. Enlarged aortic knob is seen in systemic hypertension, in aortic dissection, and in cystic medial necrosis. Next, we should check the main pulmonary artery, seen here. It can be measured by drawing a tangent line from the apex of the left ventricle to the aortic knob, and then along a perpendicular line the distance between the tangent and the main pulmonary artery. Normally, it's between 0 and 15 millimeter medially. 0 means touching this line, the white line. Okay, in cases of increased pressure or flow, the MPA, main pulmonary artery, project beyond the line, so it's more than 0 millimeter. And also it's abnormal if it's going more than 15 millimeter to the right of the line medially, seen in cases of left ventricular and aortic knob enlargement, such as in hypertension and atherosclerosis in adults. So this is a case here, the main pulmonary artery projects beyond the tangent line. So we have it could be due to increased pressure or flow. However, in this case, it was due to increased flow from left to right shunt secondary to ASD. Concave main pulmonary artery, so it's more than 15 millimeter medially, can occur in two reasons. Either the left ventricle or aortic knob enlarged due to hypertension, or we could have an intrinsic abnormality in the pulmonary artery. It's either small or absent. Next, we should check the concavity for left atrium. Usually, the left atrium has no border, forms no border of the heart on frontal projection. And when it's enlarged, it produces an abnormal contour. On the right side, the double density sign we talk about, and it's less common sign. And on the left side, when the left atrium enlarged, it will fill the concavity normally present below the main pulmonary artery, and we call it straightening of the left heart border. So when we have double density, we should always check for the other sign, the straightening of the left heart border, because the double density sign could be seen in normal individuals. Also, in cases of mitral stenosis, not only we have enlargement of the left atrium and straightening of the left heart border. In fact, the left atrial appendage will also enlarge, and it will produce an extra convexity in this region. Okay, so modes of left atrial enlargement. The left atrium could enlarge to the right side, forming the double contour. It could, to the left side, causing straightening of the left heart border. Superiorly, causing widening of the carinal angle more than 75 degrees. It could also pushes posteriorly, compressing on the esophagus. So this is a case where we can see the three signs: straightening of the left heart border, the double density, and the spraying, we call it, of the carinal angle. Okay, last, we should check for the ventricles, the left and the right ventricle. So how do we assess which ventricle is enlarged? We should evaluate the corresponding outflow tract for each ventricle. In this case, the main pulmonary artery is enlarged, such the cause is due to right ventricular enlargement. And here, we have a prominent aorta, thus it's the left ventricle enlarged. Okay, after assessing the heart size and the heart contours, we should then check the pulmonary vasculature. We could have a normal flow, an increased flow or decreased flow, a venous or arterial hypertension. How do we assess the pulmonary vasculature? We should start by looking at first on the right descending pulmonary artery, then the distribution of flow from apex to base and from central to peripheral. Okay, first, this is the right descending pulmonary artery. It should be normal in patient. Normal patient should be less than 17 millimeter. Then we should assess for the size, not the number of the vessels, on the distribution, apex. So the size is the most important factor. So we choose the right lower circle. It's taken on the right base. And we can choose either the right upper or left upper apex to check for the size. Okay, the size on the base should be larger than the apical vessel in standing patients. Third, we should assess for gradual and progressive tapering of vessels from central to peripheral. So in cases of the first abnormality, venous hypertension. When we have venous hypertension, fluid leaks from lower lobe vessel, and we have an increased resistance to lower lobe flow. Thus, we will have a redistribution of flow to the upper lobes. So as we can see here, the size and the apex is larger than the right lower pulmonary vessel. And this is called cephalization. Other signs of pulmonary venous hypertension seen in this patient with congestive heart failure include laminar pleural effusion, as we can see here, and fluid fissural effusion, which we call a pseudotumor in the minor fissure. Arterial hypertension. In arterial hypertension, the abnormality is that we have a discrepancy in the size between central pulmonary vessel and the peripheral vessel. We don't have this gradual normal tapering. We have an abrupt variance in the size from central to peripheral. Okay, so third abnormality, increased flow to the lungs. When we have an increased flow to the lung, we have all the blood vessels everywhere in the lung are larger than they would be in normal person. Includes the right descending pulmonary artery, the upper lobe vessels, and the lower lobe vessels. However, we still have the normal distribution of flow, same as in normal person. Thus, the lower lobe vessel remain larger than the upper lobe vessel, and we still have the gradual tapering of the vessel from central to peripheral. Okay, small summary. Normal case of venous hypertension with cephalization, increase in the apical artery vessel size. Here we have a arterial hypertension. We lose the gradual tapering, abrupt change in pulmonary vasculature size. And here we have an increased flow, such in VSD, where we can see that the vessels everywhere are enlarged, with gradual tapering, the lower being thicker than the upper, greater in size than the upper pulmonary vasculature. Okay, so what's the algorithmic approach? We have a mnemonic for it, the ABCD of heart disease. So after having all of these data of heart size, of abnormality of heart contour, and pulmonary vasculature, we can go and do this algorithm to get our diagnosis. The first question is the A, and the first question we ask is, do we have a left atrial dilation? And if yes, we then should check the pulmonary vasculature for either normal or venous hypertension, increased flow, or arterial hypertension. And depending on the pulmonary vasculature, we will have our diagnosis. Either mitral stenosis, left heart failure is the most common, and also all of these diagnoses. Okay, so what if we don't have left atrial dilation? If no, we should ask the second question. After A, we have B, left atrial dilation. No. Is the main pulmonary artery big or tortuous? If yes, we should also check then for the pulmonary vasculature, and depending on the pulmonary vasculature, we'll have our differential diagnosis. If we don't have atrial enlargement, atrial dilation, if the main pulmonary artery is not big, the question C stands for concave main pulmonary artery. So if the main pulmonary artery is concave, our next question would be, we should check for the aorta. It doesn't depend here in this question on the pulmonary vasculature. We should check if the aorta is normal, if it's entirely prominent, or if we have only the ascending aorta prominent, such as in this case. This is a case of aortic stenosis with post-stenotic dilation. As we can see, the ascending aorta is abnormal as it projects outward. Its convexity is projecting outward to the right. And here, the aortic knob and the descending aorta are normal. However, in hypertension, we can see that both the ascending, the descending, and the aortic knob, all of them are enlarged. And that's why we should, each case, like here, hypertension, entire aorta prominent, and depending on the aorta, we'll have our diagnosis. So what if the main pulmonary artery is not concave? Our next question would be, okay, we don't have atrial dilation, the main pulmonary artery is normal. Okay, we should ask, is the heart dilated? What do we mean by dilated heart? A dilated or delta-shaped heart is one with a cardiothoracic ratio more than 65%. And we have the heart on both sides project on the right and left side, it will be enlarged. Okay, and the two main entities in the differential diagnosis include cardiomyopathy and pericardial effusion. This is an example of a delta-shaped heart. So ABC of heart disease, sorry for confusing you, but it's easy. This is a schematic approach for this algebraic approach. The A is the left atrium enlarged. Yes, check for the pulmonary vasculature for your diagnosis. If no, main pulmonary artery big or bulbous. If yes, check for the pulmonary vasculature for your diagnosis. If no, then check if you have concave main pulmonary artery segment. If yes, we should check the aorta. And if no, we should check if we have a dilated or delta-shaped heart. And it's either cardiomyopathy or pericardial effusion most commonly. So what our take-home messages? First, we usually assess the heart size, and we should ask, is it a true or apparent cardiomegaly? Then we should assess the 7-heart contour, the aorta, the left atrium, aortic knob, main pulmonary artery, left atrial concavity, and the ventricles. After assessing these two entities, we should check for the pulmonary vasculature, if it's normal, the size of the right descending pulmonary artery, and we have the normal variation upper to lower and hilar to peripheral. Then, after collecting these data, we can go and have this algorithmic ABCD approach. Atrial enlarged pulmonary vasculature. Big MPA enlarged, look at pulmonary vasculature. Concave MPA, look at the aorta. Dilated heart, cardiomyopathy versus effusion. And this is my reference. And thank you. I didn't talk about valvular heart disease or congenital heart disease because it's gonna take so much more time. I can do it later if you want to.